Good evening. Hello. Can we start?
Yes po, ma'am.
Okay. Can you hear me?
Yes,
Hello.
ma'am.
Teka, check ko lang kung nandito na ba si Cecil Vinyas, yung medrep ng Abot? Yan, nandiyan na. Sige, okay. Good evening, everyone. I'm Dr. Patricia Ko. So welcome to this talk about postoperative fever. First, I'll show you the comic strip that I painstakingly made. Dito ako nahirapan. Naubos ang oras ko gumawa ng comics. Yan. So, postoperative fever, in a nutshell, it can be due to wind. So, wind, di ba? Ito yung mnemonics that we are very, that we all know, that you should know. This is a nice mnemonic. Wind, so it can be due to pneumonia or atelectasis. Water, if you have UTI, it can also cause postoperative fever. Wound, so if there's a wound infection or an infection of the operative site. Walk, so ibig sabihin nito, if there's deep vein thrombosis, superficial thrombophlebitis, can lead to fever. Wonder drugs, what is this? It means that there are also causes of fever because of medications, no? Drug-induced fever. And what the fuck? What the hell? What is this? No? So there are also other occult cases of causes of fever which are less common. So of course, I will not be talking about each and every one very extensively. This is just an overview. It's still up to you to read on your own. I will share my slides now. So please, after this talk, there will be a quiz, and then there will be prizes care of our very nice sponsored for today, which is Abbott. Ma'am Cecil, how many prizes do we have? Okay. Anyway, so postoperative fever. So postoperative fever is defined as temperature greater than 38 degrees Celsius 24 hours after the operation. It means that the first 24 hours right after the operation is still not considered fever because you can also just have dehydration right after surgery. So yung post-op fever is after the first 24 hours post-op. Okay? The most common causes of fever are atelectasis, pneumonia, so yun yung wind, UTI, that's water, phlebitis, that's the walk, wound infection, that's wound, SSI, that's also part of wound, operative time, prolonged operative time of more than 2 hours leads to a higher risk of fever, intraoperative blood transfusion, and drug fever. Okay. So whenever you have a patient who develops fever, you're like a detective. And I know it's scary. don't like it, no? So you're a detective because you have to know what is the cause of the fever. You have to dig around. So in 20% of cases, it is infectious. And in 80%, it's not infectious. So the causes of fever that is not infectious is actually higher. Therefore, if you have a fever patient who is febrile, do not automatically give an antibiotic left and right. You have to investigate because maybe it's not an infectious cause. So this is a very nice graph. No? It shows the timeline when fever occurs and what is the most likely cause. So if it is due to atelectasis, fever occurs very rapidly, no? Within the first to the third day post-op. Pneumonia occurs usually around day 3 up to 1 week or more. For wound infection, if the fever occurs very early, 1 to 2 days post-op, it is due to a streptococcal or a clostridial infection, which is usually managed by antibiotics that cover for gram-positive organisms. If you have other bacterial infections, then such as gram-negative anaerobic infections, the fever occurs later, starting day 5 and later. This will include chlamydial infection. The fever might occur around day 7. For ovarian abscess, the fever can occur at around day 7 or even later. For cough cellulitis after hysterectomy, fever starts at around day 4. For phlebitis, superficial phlebitis, by the time around day 4 post-op, if the patient still has an IV line, that patient may develop fever. That is why we don't really encourage prolonged IV line use. For deep phlebitis, fever occurs at around day 3. UTI, it starts at around day 3 post-op. And for ureteral or bladder injury, it's later, no? Around 1 week post-op. So you have a problem of post-operative fever after the first 24 hours. So look at the history. If it's catheter related, so it's because of a catheter associated UTI, the fever is very abrupt. Now, if it is a wound or a pelvic infection, the fever is low grade and it is gradual in onset. For pelvic thrombophlebitis, what you can do if you suspect it, you can give IV heparin for 72 hours. And this will be both diagnostic and therapeutic because if the fever lyses after giving the low molecular weight heparin, this will diagnose pelvic thrombophlebitis and will also treat it. Now, among the elderly, it's important to remember that infection may not manifest as fever. Most of them actually are hypothermic and they don't even have leukocytosis, but it is more common for them to have mental status changes. For drug-induced fever, which is also not that rare, if you discontinue the drug, you will notice a sudden disappearance of fever. And the most common causes of drug-induced fever are the sulfa drugs. So the sulfamethoxazole, sulfasalazine, also allopurinol, carbamazepine, phenytoin, vancomycin, which is ironically an antibiotic, minocycline, dapsone, and patients who are HIV positive or the elderly suffer more of drug-induced fever. Blood transfusion reaction. So sometimes after giving blood transfusion, patients can have fever. So that is just a BT reaction, no? Inflammation secondary to blood transfusion. That is why I always teach the residents, you don't always have to treat anemia with the blood transfusion. Treat blood transfusion carefully. Use it only if necessary, really necessary, and if the hemoglobin is less than around 70 to 80. But once the hemoglobin reaches 80, there are other methods to increase your hemoglobin, such as the hematinics, the iron sucrose, the iron sucralfate, etc. Because blood transfusion also carries risks such as infection, for example, HIV or fever, etc. Now, very, very important when you are investigating the cause of postoperative fever is the physical examination and laboratory tests. But what is really important is PE. Now, for laboratory tests, do not do decahon routine, um, do all the lab tests. No, you have to assess what is important because for cost effectiveness. Okay. So for physical examination, what do you have to check? Listen to the lungs. Listen, are there very fine crackles which may signal the presence of atelectasis or microatelectasis? Are there coarse crackles or rhonchi which may indicate pneumonia? Look at the wound, no? Is there redness, induration in the wound which may indicate a wound surgical site infection? Is there a hematoma around the wound edges or in the operative site, which may be secondarily infected or which may cause pain and inflammation leading to fever? Look at the operative site because there may also be infection or hematoma. Look at the costovertebral angle. Is there tenderness, which may suggest pyelonephritis? Look at the superficial veins in the arms where you have your IV line because you may notice superficial phlebitis, which is also an important source of fever. And the legs, assess the legs because the patient may have deep venous thrombosis. And as I mentioned, laboratory tests are ordered, but not routine. No? It depends on what your suspicion is. So what are the common laboratory tests? CBC to check if the patient has leukocytosis, to check if the patient is anemic, which may indicate possible hematoma. Chest x-ray, of course, to rule out or rule in pneumonia. Urinalysis to check if the patient has UTI. Urine CS is optional. Blood CS as well as wound GSCS. So of course, if the patient has a wound discharge, which looks infected, you really have to do a wound GSCS. Now, if the patient still has a persistent undiagnosed fever, and then you looked at the common culprits, they're all negative, then you may do an ultrasound or a CT scan to check for ureteral obstruction, an abscess, a deep abscess, or a foreign body. So in short, do not be decahon, no? There are also rare causes of fever. Pulmonary embolism, which can be fatal, thyroid storm, malignant neoplasm, bowel injury, and other infections such as hepatitis, COVID. In the book Comprehensive Gynecology, COVID was still not part of it. But now, of course, we have to, whenever a patient has fever, we have to think of this, dengue and HIV. So I had a patient before who was referred to me. She was post-cesarean section. She looked fine, but she had persistent fever. The wound was good. She didn't have UTI or pneumonia. And lo and behold, she had hepatitis A, which incubated before she was admitted in the hospital. She didn't have any other symptoms except fever. Okay? So respiratory complications after an operation are really very common. Why? Because after a surgery, especially abdominal or pelvic surgery, there's post-operative pain. And because of the pain, the patient has very shallow breathing, leading to poor ventilation. And the poor ventilation can lead to respiratory problems. So, atelectasis is the most common cause of post-op fever. And there's a failure to maintain patency of the small pulmonary airways and alveoli. So the classic triad of atelectasis is fever, tachypnea, tachycardia within the first 72 hours post-op. So it occurs early post-operatively. And usually it resolves spontaneously on the third to fifth post-operative day. So if this is just atelectasis without concomitant bacterial infection, then there's no need for antibiotics. So there's also something called microatelectasis, wherein the small airways, which are less than 1 millimeter in diameter, become blocked by secretions. And the atelectasis can progress. So if we do not immediately address the atelectasis will get worse. Then the patient will have a decrease in oxygen saturation. There's a decrease in arterial oxygen pressure, and therefore we note a low or normal to low arterial carbon dioxide, and this can progress to pneumonia. So atelectasis, if left untreated or if it becomes worse, can progress to pneumonia. So the risk factors for atelectasis are a supine position. So it's also the same as almost the same as in COVID. That's why in COVID patients, we try to avoid them to be in supine position, because putting the patient in supine position really prevents the expansion of the dependent portions of the lung. No? So we try to put the patients on an upright position immediately post-op. Okay, so we try to tell our patients to move, to sit, to stand to prevent atelectasis. Obese patients are more prone to atelectasis. Smokers, those people who are more than 60 years old, if the operation was prolonged, if there's an NGT, if there's a coexisting medical condition, laparoscopy is more a risk factor for atelectasis, because if the oxygen pressure is not really balanced, it may lead to collapse of the dependent portion of the lung bases. If the patient is doing chest breathing and not diaphragmatic breathing because it's painful, no? So how do we prevent atelectasis? We teach them to mobilize early, to ambulate early, to be in an upright position. And very important is good pain relief, because if they're not in pain, their breathing will be less shallow, will be deeper, and therefore there's better expansion of the lungs. And the good old incentive spirometry is still very effective. Okay. And usually with all these conservative measures, the atelectasis will resolve after day 3 post-op. But there's also pneumonia. So this is a usual sequela of atelectasis. So we know that pneumonia, the signs and symptoms are fever, cough, dyspnea, tachypnea. There can be a purulent sputum, except if it um, atypical pneumonia. And there can be chest or back pain. On physical examination, we notice coarse rales, high fever. So usually the fever is higher in pneumonia compared to atelectasis. And the patient is also more toxic looking than a patient who has atelectasis. On laboratory test, CBC shows leukocytosis. Chest X-ray shows really more severe appearance of the X-ray, because there are diffuse patchy pulmonary infiltrates, unlike in atelectasis where the infiltrates are really very, very fine. Sputum gram stain may show lots of inflammatory cells and bacteria. And the treatment is the same as atelectasis, but of course we have to give antibiotics. So the antibiotics that we'll give will depend if this is a community-acquired pneumonia, hospital-acquired pneumonia, or ventilator-associated pneumonia. So if this is hospital-acquired pneumonia, it means that the fever, the pneumonia occurred more than 48 hours after hospital admission, and ventilator-associated pneumonia means that the pneumonia occurred more than 48 hours after intubation. So for the community-acquired pneumonia, it will depend on the sensitivity pattern in that area in the hospital. For hospital-acquired or ventilator-associated pneumonia, with no risk factor for drug resistance, the antibiotics of choice are ceftriaxone or ampicillin or levofloxacin or ertapenem. No? So the carbapenem does not have to cover for Pseudomonas. Now, if hospital-acquired pneumonia or ventilator-associated pneumonia has a risk factor for drug resistance, so when do we expect that the infection is drug resistant? If the patient took antibiotics within the past 3 months, if the patient has been hospitalized for more than 4 days, if there's a high frequency of resistance in the hospital, and if the patient is immunosuppressed. So in these cases, then we have to give stronger antibiotics, cephalosporin with anti-pseudomonal properties such as cefepime or ceftazidime, or anti-pseudomonal carbapenem such as imipenem or meropenem, or piperacillin tazobactam. If the patient has methicillin-resistant Staph aureus, then the drugs of choice are linezolid or vancomycin. But we are really limit these antibiotics. We are not even allowed as obstetricians to just give these antibiotics. It has to be with the concurrence of the IM infectious disease specialist, because these antibiotics can have a higher toxicity profile and are also quite expensive. And we are trying to limit their use to prevent resistance. If our patient is at possibly high risk for aspiration pneumonia, for example, she has been intubated and then she had post-operative nausea or vomiting, we're highly considering aspiration pneumonia. So the drugs of choice are clindamycin or coamoxiclav or amoxicillin plus metronidazole. Therefore, this slide shows that we really have to give antibiotics judiciously, because imagine just giving an antibiotic within the past 3 months puts a patient at risk for drug-resistant bacteria. So we really have to do judicious antimicrobial prescription. That's why sometimes in our patients who are long staying patients in the hospital who have been given so many antibiotics, we will notice that their bacteria are so hard to treat. They're already the multiple drug resistant bacteria, wherein the only drugs that are left are the IV antibiotics, the imipenem, the meropenem, and we don't have the armamentarium is already very limited. So if we can avoid giving antibiotic, please do so. Okay. Okay, so if a patient post-operatively aspirates, there's really a risk of chemical pneumonitis. And this chemical pneumonitis can lead to ARDS. And a secondary bacterial infection can also ensue. So how do we manage it? We have to do early removal of the NGT, and then usually the anesthesiologists are proactive. They immediately give antacids for patients who are at high risk of aspiration pneumonia. No, they give already H2 antagonists or proton pump inhibitors, and we give sedatives very carefully to prevent also aspiration pneumonia. Okay, another possible consideration for post-op fever is hematoma. Hematoma by itself is not an infection, but a big hematoma, of course, induces an inflammatory reaction, which can lead to fever. So the fever does not necessarily mean that it's an infection. It can be just due to inflammation. But the hematoma, if it's large, can lead to a secondary bacterial infection. So Risk factors for hematoma formation postoperatively are patients on anticoagulant therapy or those who really had very extensive surgery and very bloody surgery. Signs and symptoms of hematoma are a sudden drop in the hemoglobin at around day 3 postoperatively. And then there's mild to moderate tenderness on the affected area. There may or may not be fever, and there's a palpable mass at around day 5 postoperatively. A retroperitoneal hematoma cannot be seen, of course, because it's very deep, but it can be diagnosed by careful bimanual examination or by ultrasound or sometimes by CT scan. So how do we manage hematoma? Not all hematomas are surgical. So if it's less than 5 cm in diameter, it's possible to do conservative management. It can also lyse, and then we give uh, like tranexamic acid. But if it's 5 cm or more, it's better to drain it. So ideally, it's better to do it by CT or ultrasound guided drainage to avoid exploratory laparotomy. This is because big hematomas, there's really a greater likelihood of a secondary infection. Now, this is already rare because in the operative site, um, we are very conscious of pad count and counting all the sharps, no? But sometimes retained foreign body can still happen. So sometimes a foreign body or a sponge gets secondarily infected when it is left behind uh, the operative field. So this more commonly happens if the surgery changes, like the plan of surgery changes. Within the first post-operative week, uh, there is a tender pelvic mass. However, if the foreign body has been there already for a long time, there is already very minimal tenderness or the patient is already asymptomatic, but can still manifest with low-grade fever. Of course, the treatment for a foreign body is removal of the foreign body. Superficial thrombophlebitis is also a very common cause of postoperative fever. It is associated with IV catheters. Usually, superficial thrombophlebitis is benign, but it can also progress and cause deep venous thrombosis in 5%. So on physical examination, you will note superficial erythema and tenderness of the veins. And there can also be a tender nodule at the area of the IV insertion, no? The patient has a fever. There can also be superficial thrombophlebitis in the form of painful varicose veins, which may predict the presence of deep venous thrombosis. So sometimes the varicose veins, which are in the legs, which are superficial, may also predict or predispose that person also to a deeper venous thrombosis, DVT. There may be an infected blood clot at the tip of the IV catheter. And the management is to remove the IV catheter at the first sign of induration, edema, or erythema. So if you note that your patient already has swelling of the hand, or when you touch the IV catheter site, it's tender, it's red, just remove it, no? Don't try to prolong that IV catheter site because this is already a source of infection and fever. So routine exchange of IV catheters is not indicated. So when I was a med student before, we used to have to change the IV line every 3 days. But of course, this is quite difficult for patients who have very small veins, no? So in case that the patient has to be on prolonged IV catheter, we don't have to routinely change it, only if there's already evidence of infection. So what do? We have to remove the IV line, we have to rest the arm or the leg, elevate it, and apply local heat. So if the thrombophlebitis is moderate to severe, we can give NSAIDs, we have to give heparin or low molecular weight heparin, and we may or may not give antibiotic depending on the situation. Now we go to the more complicated or the more serious form of phlebitis, which is deep venous thrombosis. So deep venous thrombosis, 75 occurs within the first 72 hours. So usually it's really in the first 3 days. But there are some cases wherein it happens 1 week post-operatively or even later. Now, DVT, as we know, can be very serious because it can lead to pulmonary embolism, chronic venous insufficiency, and post-phlebitis syndrome, which is defined as the shunting of blood to the superficial veins, chronic edema, pain on exercise, and skin ulceration. And occasionally, DVT can lead to pulmonary embolism and death. So the pathophysiology of pulmonary embolism is that there is venous stasis. And when there's venous stasis, so the blood doesn't flow back to the heart, then there's anoxia and thrombus formation in the vein. No? So there's thrombus, no? There's a blood clot in the vein, and this damages the vein wall, and the basement membrane is exposed. So when the basement membrane is exposed, there's damage to the walls of the vessels. The platelets adhere because we know that the platelets are very sticky. They adhere there. There's local coagulation, and the clot begins at the base of the valve cusp. Now, new thrombi are not firmly attached. They are very free. They can really throw off thrombi, and they are the ones that are more likely to become pulmonary embolism. No? So new thrombi are more dangerous. So on physical examination, actually, 50% of patients with DVT are asymptomatic. Now, the other 50% have symptoms such as pain and warmth in the calf, edema, swelling, persistent low-grade fever, with tachycardia and difference in leg circumference. So the most pathognomonic physical examination findings in deep venous thrombosis are persistent low-grade fever, tachycardia, and there's a difference in the leg circumference between the left and the right leg. No? So you will really suspect DVT. So usually the tachycardia is not for example, if the patient is only very mildly anemic, but you can see that she is very tachycardic, so you can suspect deep venous thrombosis instead of anemia. So the laboratory tests which can support your diagnosis of deep venous thrombosis are the duplex scan, the Doppler ultrasound, and ascending contrast venography. What about the dimer? We commonly order for that if we suspect DVT. However, immediately post-op and in pregnant women, D-dimer is not that reliable. There can be false positives. So for laboratory tests, usually what will be more indicative of DVT are the duplex scan and the Doppler ultrasound. So how do we manage? Prevention, remember that DVT, it's better to prevent it than to cure it because management of DVT can be quite difficult. Because once there's already a thrombus, the anticoagulant will just interrupt its progression. It will not really dissolve the clot, but it will just prevent further progression of the clot. And it's important to treat this very fast. Give this within 24 hours of the disease. So treatment, I read about this. In Europe, what is the preferred drug of choice is fondaparinux, which I don't think is available in the Philippines. In the Philippines, what we most commonly use is low molecular weight heparin, either a subcutaneous or IV infusion. We commonly give enoxaparin 1.5 milligrams per kilogram once a day. So the advantage of enoxaparin is it is short acting, and it has a very good safety profile. Unfractionated heparin is also given. However, it is less safe and it is also less effective. So there are more cases of bleeding tendencies with unfractionated heparin. Treatment is usually given for 3 to 6 months. So it is not a fast, you have to really give it for a prolonged period of time. We monitor for low platelet, less than 100,000 per cubic millimeter. And we have to also prescribe support stockings, which should be used for several months, up to 2 years, for severe cases of DVT. Now, the most severe form of DVT, the end, which can really be fatal, is pulmonary embolism. Many of these patients who suffer from pulmonary embolism are asymptomatic until they really suffer from the symptoms of chest pain, dyspnea, apprehension, and occasionally death. No? So the common symptoms are sudden. No? Usually it's very sudden, chest pain, dyspnea, and then the feeling that they're about to die, parang they have a feeling of impending doom. The signs are tachycardia, tachypnea, sudden onset of rales, an increase in the second heart sound over the pulmonic area, and 50% have unexplained low-grade fever. Some develop syncope, and rarely, but it happens in 8 to 10% of cases, there can be death. Laboratory tests to diagnose pulmonary embolism is the same as in DVT. And there's also what we call a VQ scan. I think this is a ventilation perfusion scan, which has an excellent specificity. Treatment is the same, no? Low molecular weight heparin, IV heparin, and thrombolytic therapy, streptokinase and urokinase. Now, what is a very common cause of post-op fever? We know this. It's UTI. Most commonly, post-op, it's because of an inability to void. Because sometimes the bladder has been distended, or the patient does not feel the urge to urinate because of the effect of the anesthesia. So the inability to void, of course, predisposes the patient to UTI because there is bladder atony and bladder over distension of the bladder. No? So how do we prevent UTI? If a woman is pregnant and she's in labor, remember to make her urinate every 2 hours. We have to remind her. So usually women who are in active labor, because of either the labor pain, she forgets to urinate, or she doesn't drink enough water, she's dehydrated, it predisposes her to UTI. Multiple IEs, of course, can also infect the urinary tract. If the woman naman is on epidural anesthesia, she loses the sensation to urinate, and then there is also bladder distension. So we have to also avoid bladder retention, especially in epidural anesthesia. So remind her to urinate every 2 hours. So again, as I mentioned, urinary tract infection post-operatively or postpartum, it's frequently caused by the inability to void. Also, it can be caused by prolonged urinary catheter use. No? So in the hospital setting, there's what we call CAUT, no? Catheter-associated urinary tract infection. So those who are on urinary catheter are at higher risk of developing UTI. And the definition of CAUT is on urine culture, there are more than 100 organisms per ml of catheterized urine. So, of course, this follows that we try to avoid excessive catheterization. And how do we avoid CAUT? So there's what we call the CAUT care bundle. So there's a bundle of care in order to avoid catheter-associated UTI. So remember to catheterize only if necessary. We do not catheterize patients just to manage their incontinence. So sometimes some people are already incontinent, they're very old, they cannot go to the bathroom. Catheterization is not the solution because this opens a bag of worms, no? Makes that person more prone to UTI. Also, remember to use a catheter for as short a time as possible. So if that patient underwent surgery, for example, cesarean section or a hysterectomy, the catheter should be left in place for less than 24 hours. Actually, there are now studies proving that right after a cesarean section, they would even advise removing the catheter right after cesarean section. This is not yet the norm, but more and more surgeons have been trying to decrease the time of that urinary catheter in place. So probably we can reduce the uh, catheter after cesarean for only 12 hours post-CS. And this will also encourage that patient to move faster, right? To walk and to go to the bathroom if that catheter is removed after 12 hours. Whenever you will catheterize, remember to catheterize aseptically and gently, because that's why whenever I have a patient for operation, I really look at the nurse or the resident who will insert the catheter and who will put preoperative antiseptic, because aseptic technique is really very important to prevent UTI. And catheterize gently, because once we damage or we injure the urinary tract epithelium, there's really a higher risk of UTI later on. Remember to do hand hygiene before and after touching the catheter, no? So, tinitingnan ko talaga yan. Is the surgeon using sterile gloves when touching the catheter? Is the surgeon touching the skin or other parts of the body, or using the same gloves in prepping the skin, and with that same pair of gloves touching the catheter? So that's a no-no, no? That catheter really has to be sterile before inserting it. And we have to properly secure the urinary catheter to the patient's legs to avoid traction, because if we don't attach the catheter to the legs properly and then that catheter is pulled, of course it's very painful and it will cause trauma to the bladder and to the urethra and lead to UTI also. Use the smallest bore catheter possible to prevent trauma to the urethra and to prevent UTI. Use a closed system, of course. So the catheter and the urobag should be a closed system. Keep the urine flow unobstructed. So it's no. Sometime before, when I was a resident for women with urinary incontinence, we will do yung, sometimes we will clamp the urinary catheter to do bladder training, but this is no longer routine standard of care, because this induces more cases of catheter-associated UTI. So the urine flow should be unobstructed. There should be no kinks in the catheter and in the urobag. Now, changing the Foley catheter and the urobag routinely are not recommended. But whenever the patient is in prolonged catheterization with that catheter in place, we have to clean that catheter and the urobag. And because there's a biofilm that forms in the catheter, which attracts also the bacteria. Important, do not place urobag on the floor. Okay, that's very, very important. So sorry, I'm very sometimes OC and I look where the nurse puts the urobag, di ba? Before CS or before hysterectomy, it should be hanging on the table, side of the table of the operating table, and not place it on the floor. However, the urobag should also be below the level of the patient so that the urine will flow downward through gravity. Now, the treatment of catheter-associated UTI, of course, common sense, remove the Foley catheter. Hopefully, there's no need to reinsert a new Foley catheter, and give antibiotics. So for CAUTI, usually it's more difficult to treat compared to ordinary UTI. This is already a complicated UTI. So the antibiotic has to be given for at least 3 days. So a single dose antibiotic will not cut it for this case. So thank you very much. Do you have any questions? Meron? Okay. Meron ba kayong mga case na, what are the most common causes of postoperative fever? Sige, magtatawag ako. In East Avenue Medical Center, Jenny, na 2L. In your experience, what's the most common cause of postoperative fever? Jenny?
Ano po, ma'am? Atelectasis po, ma'am.
Okay. So, what about Nina? Is Nina Kiat here? Somebody from Makati Med? Meron ba? Anybody? Nina, are you here? She's not here. Okay. Somebody from St. Luke's? Meron ba? From St. Luke's? None? Anybody from St. Luke's? Or is COVID the most common cause of post-op fever? Okay, all right. Any sharing? Do you want to share anything? Puro ba tayo East Up today? And the interns? There are a lot of interns. Okay, so now Ma'am Cecil of Abbott will be having a short product presentation. So can we listen to Cecil? After that, we will be having like a question, no? I will try to check if you listen to my lecture, and then I will ask some questions. You can either write the answer in the chat box, or you can just talk, and then afterwards there will be prizes. Okay?
Hello, Doctora. Thank you so much, Doctora Patricia Ko, for inviting us tonight. I'm Cecil Gloria. I am the medical representative of Abbott Laboratories. And with me is my counterpart, Ms. Luzviminda Lugo, and my district sales manager, Mr. Alan Dinglasan. And thank you, Doctora, again for letting us sponsor this lecture, Doctora. And we will just be showing you a short AVP presentation, Doctora. And since it's a Women's Month, Happy International Women's Month, Doctora. And here is our video, Doctora. Thank you po. And Doctora, about the price po, I'll text you po the prices. Thank
How
you.
many ba? Para so that I know how many questions I will ask.
Actually,
One?
Doc, two winners
Two.
po of
Sige.
meals po, Doctora, will be
Okay.
to be delivered po, Doctora.
All right. Thank you.
Thank you, Doc. Doctora, pa-allow na lang po ako ng share screen po. Thank you.
How do I allow share screen? I don't know how to do it. Meron bang ibang administrator? I don't know how to allow share screen of others.
Doktora, yung isa ko pong name, yung Abbott Cecil po. Okay lang pong pa-share screen po. Thank you.
Ano ba yun? Paano? Hindi ako marunong how to do allow share screen.
Ayan, sige po, Doc. Ayan, co-host na po ako, Doc.
Okay.
Ayan po. Thank you.
Thank you.
Progesterone is a steroid comprising of 3 cyclohexane rings and 1 cyclopentane ring. It is manufactured for therapeutic use from the wild yam root Dioscorea species. Due to rapid first-pass liver metabolism, progesterone has variable concentrations and very low oral bioavailability. Therefore, it is administered via injection or vaginal route, which are not easy to use and associated with side effects. Dydrogesterone was introduced for clinical use under the trade name Dufaston in the 1960s for treatment of conditions associated with progesterone deficiency. The manufacturing process of dydrogesterone is highly complex. It starts with the chemical modification of progesterone, followed by a critical phase of transformation into dydrogesterone. This is done by passing it through UV light at an appropriate wavelength, intensity and time sequence, resulting in a unique, modified retrosteroid structure. This manufacturing process makes dydrogesterone the only commercially available retroprogesterone. The bent conformation of oral dydrogesterone enhances the rigidity of the molecule compared to progesterone. Due to its unique structure, dydrogesterone is highly selective for progesterone receptors, supplementing deficiency of endogenous progesterone. It has negligible interaction with other steroid receptors, resulting in a lack of androgenic, estrogenic, glucocorticoid and mineralocorticoid effects that can occur with other progestogens. Dufaston, containing 10 mg dydrogesterone in each tablet, is formulated to have good bioavailability, enabling convenient, patient-friendly oral administration. Improved oral bioavailability and the receptor agonist activity of its metabolites causes secretory transformation of the endometrium, progestational activity, at a dose 10 to 20 times lower than micronized progesterone. Various progestogens have been investigated to support endogenous progesterone in the treatment of luteal phase deficiency. Only Dufaston, progesterone, and 17-alpha hydroxyprogesterone caproate are currently approved for clinical use during pregnancy. In addition, Dufaston has a wide range of indications to supplement endogenous progesterone deficiency. It is shown to be effective in irregular menstrual cycles, dysmenorrhea, endometriosis, premenstrual syndrome, and secondary amenorrhea. In women undergoing assisted reproduction, Dufaston supplements endogenous progesterone and provides orally effective luteal phase support, contributing to successful and comparable pregnancy outcomes versus vaginal micronized progesterone. To date, around 113 million women throughout the world have experience with Dufaston, including 20 million fetuses exposed to dydrogesterone in utero.
Thank you so much, Doctora and our dear doctors. We'll be showing another presentation, and with that, my product, I would like also to reinforce again. I'm handling Dufaston, Ibret Folic, Duvadelan, and Second Calcium DE. And with my counterpart, Luzviminda Lugo, she's promoting Duratacine. Yes, Luzvi.
Hi, good evening, doctors. Thank you for the opportunity. I'd like to mention about my product, which is Duratacine. It's for indication of prevention of PPH. Again, a single injection, lasting prevention. This is a PNF approved, which means your patient can have it covered with PhilHealth. The other one is Dupalac fruit. This is a lactulose. Again, and lastly, Profess. It's a vaginal ripener. Progress with Profess. Thank you so much and have a good night.
Abbott celebrates International Women's Month.
Hello? Naputol?
Yes, Doc. We'll rewind na lang po, Doctora. It's a 30-second video lang po, Doc. Thank you.
Abbott celebrates International Women's Month. Presenting Abbott Women's Health Camps. To the women around the world who shape our future. We celebrate your acts of courage and determination in these trying times. Thank you, Doctor.
Ayan. Thank you so much, Doktora. And thank you again for the opportunity po.
Thank you very much.
Thank you, Doc.
Salamat po.
Lisa of Abbott. And
Yes.
Sir Alan. Thank you for sponsoring our talk for today. So I have a question to you. Do your products cause postoperative fever or postpartum fever? Carbetocin, Dufaston, Dufalac.
With Dufaston, Doktora, we don't cause operative fever po, Doc.
Doesn't cause fever.
Yes.
What about the Duratocin? Can it lead to fever?
Doktora, wala rin po.
Minsan, di ba, as I mentioned, there can be drug-induced fever. So, we have to know what are the possible side effects of some drugs. So, can they cause fever or not?
Actually, Doktora, yung sa amin, among the carbetocin that we have in the market, Duratocin is the safest compared to that. But then, we all know on each body reaction with the drug, it can also cause the fever. So, depende na lang po yun. But then, we have studied that Duratocin is the safest among carbetocin that we have in the market. And we already have the RTS, which is room temperature as well with Duratocin.
Thank you.
Thank
so,
you,
yes,
Doktora.
it can lead to, but this is usually just transient fever.
Yes, Doktora. Yes,
First
yes.
24 hours postpartum, and usually pagka naman ganon, we don't think of infection, right? It can
Yes,
be
Doktora.
normal for women to have a little bit of fever immediately postpartum. So thank you so much.
Correct, Doktora.
So
Thank you.
now we will go to our quiz. I hope you listen because there will be 2 beautiful prizes care of Abbott. So parang gift certificate, no? Na
Yes.
food delivery.
Yes, Doktora. I will just get na lang po, Doktora, their names, address, and contact number, and we'll be sending them a meal, Doktora, worth 1,000 pesos po, Doktora.
Can they choose the meal that they want or no choice talaga?
We can actually ask naman them, Doktora, or I'll
Okay.
contact them personally, Doktora.
Oo, kasi baka
Opo.
may mga dietary di ba?
Yes po, Dok. And also,
Yes.
Doktora, kasi we would like also to yung i-assure yung contactless, Doktora. So, yeah,
Safety.
for the safety of all. So, I will get in touch with Doktora with them if they have their own
Reference.
personal choice or reference po, Doktora.
Okay.
Thank you, Doktora. I like your
Very
lecture po.
much.
I learned a lot.
Okay.
Very
Thank
informative.
you.
All
Doc.
right.
Yes, Doc.
So, first question.
Salamat, Doktora.
Hi, Sir Alan.
Kumusta po
Thank
kayo?
you.
Thank you po.
Thank you very much also. Okay. So, first question. A patient is day 3 post-tabiso and she developed temperature of 38 degrees Celsius on day 3 post-tabiso. Her oxygen saturation is 95%. On auscultation, you noted very fine adventitious sound. So what is your diagnosis? Okay, the first person who answered is Dr. Rosete. Leana, can you give your answer? Dr. Leana?
Doctor, I answered atelectasis po.
Yes, very good. So why is it atelectasis?
Because the patient had fine crackles on auscultation.
What else?
And it occurred on day 3. Atelectasis usually occurs on day 1 to 3 of post-op.
Yes, and what is the characteristic of the fever? High grade, low grade fever. Usually. Is it a high grade fever, 39, 40 degrees, or is it 38 degrees, low grade fever? Sinat lang.
Low grade fever.
Grade fever. Very good. Okay, so Doctora Leana Rosete, you won a gift certificate of food delivery. So please, so can you just, paano kaya? You can message me privately your name, cell phone number, and your address. So it can be delivered straight to your house. Thank you so much. Are you an intern, Dr. Leana?
Doc, I'm a second year resident po from
Ah.
East Philippines.
Okay, sorry. Hindi kita kilala. I'm so sorry. Okay. Thank you, Liana. Okay, the second question. What are the classic signs on physical examination of deep venous thrombosis? So the three classic signs, dapat tatlo yung sagot nyo ha, of deep venous thrombosis. We have a winner, Dr. Alisa Rose Aurelio. Okay, can you tell us your answer, Alisa?
Doc, hello po. Good afternoon. Doc, ang answer po ay tachycardia, different in leg circumference, and persistent low-grade fever.
Very good. Okay, so those are the usual physical examination findings of DVT. So excellent, you were listening. So please write in the chat box directly to me your name, cell phone number, and address. Thank you. Okay, so thank you very much, everyone. I hope you learned something today, and I hope you will attend next week for another OBID rounds with prizes, of course. Thank you. Good night.
Thank you,
Doctora. Good
Very
night po.
Thank you to Abo.
Thank
Thank you, Doc.
Salamat din po, Doktora. Salamat po.
Thank you. Thank you so much.
Thank you.
Sana pwede pa uli kayo mag-sponsor.
Siguro po, next
Yes,
month,
Doc.
Doktora.
Nandiyan po si Sir Alan. Pwede po.
Ayan, pwede siyang mag-ano dyan.
Thank you.
Siguro, Doktora, next month po. Sabihin ko po, kung may next month pa ulit, Doktora. Okay po.
Sige, sige.
Next month daw, Doc.
Thank you.
Salamat po.
Kailangan natin ng mga dear residents and interns. Sila ang mga true frontliners.
Yes, opo.
Yes,
That's true,
tama.
Doktora. Thank you, Doc. Have a good
Thank you.
Salamat po.
Bye-bye.
Bye-bye.
Stay safe, guys.
Bye-bye po.
Bye-bye.
Thank you. Teka, kopihin ko lang. Alisa. Paki-ano na lang paki-save na lang yung video and then we will save it on YouTube. Thank you so much. Good
Opo,
night.
ma'am. Okay
Stay
po. Thank you po,
safe.
Doc.
Musta na kayong mga resident, yung mga na-COVID?
Quarantine po, Doc.
Pero mga ano ba, severe yung symptoms nyo, oxygen requiring o hindi naman?
Hindi naman po, Doc. Flu-like symptoms lang po.
Malalakas pa yung mga katawan nyo. Well, buti na rin para may antibody na kayo.
Oo nga po, Doc.
Sige, ingat. Bye-bye.
Thank you, Doc.